Hi, everybody. Wherever you are around the globe, welcome to the worldwide webinar brought to you by the World Society of Pediatric Ophthalmology and Strabismus. This is episode 2, Strabismus Techniques. My name is David Granet, and I am coming to you live from San Diego, California, in the United States of America. We have specialists for you from around the globe, from San Diego going all the way around the globe to Australia. We have last time people who are listening in from over 50 countries. We have people that are from every city imaginable, from New York, from London, from Leicester City, the home of the greatest soccer club in the world. We have people from Geneva, from Berlin, Barcelona, Madrid. We have people coming from every part of Africa, the Middle East, Australia, New Zealand, Singapore, one of my favorite places, Hong Kong, a wonderful place, China, the subcontinent of India is listening in. We have people from the Philippines, and one of them I'm going to say happy birthday to. Dr. Rick Ventura, I know today is your birthday. Happy birthday. Joining us today, we have an incredible panel of people that you're going to get a chance to listen to. A few housekeeping issues to start with. One, the World Congress of Pediatric Ophthalmology and Strabismus is 5 months and 1 week away. We hope it will be the coming out party to end all coming out events for all of us worldwide to get together in our field and join hands and really enjoy being together and be able to join hands without wearing gloves. We hope. We have plenty of time to decide whether or not that event will go on. As of now, it is on, and we hope to see you there. Additionally, today, if you have questions during the event, please type those questions into the platform that you're on. We have people monitoring Facebook. They will test the questions. If you are on the Blueberry platform, we will see those questions directly. Our monitors will see those, and those questions will get asked. So please participate with us. With that said, we also want to thank NTOD, the sponsor for this event, who has made it all possible. This is their platform we are using. Thank you for joining us today. So I'm about to share my screen, and I will introduce first my co-moderator, and then we'll go from there one step at a time. So bear with me as I now share my screen. Here we are, all of us for Worldwide Webinar Episode 2 together. Let me tell you just a little bit about my co-moderator, Angela Fernandez. Angela is quarantined in Colombia and doing her outside walking on her inside treadmill. She is a superstar in the field of pediatric ophthalmology and strabismus. She's director of pediatric ophthalmology and the adult strabismus service, and an associate professor at the military hospital in Nueva Granada University, Bogota, in the beautiful country of Colombia, not Colombia, which she has told me many times as my son graduated from the university, not the country. We made sure we spelled that right. Angela has also asked that we mention the fact that tomorrow, Claude will be holding a meeting with a speaker, Joe Deemer. Angela is co-moderating that along with Federico Velez, who helped moderate our first session last week, and Doctors Mendiola and Prada. That will be tomorrow, Monday. That's going on, brought to you by the incredible association, CLADE. The World Society of Pediatric Ophthalmology and Strabismus believes expertise resides all over the world, and we hope that you are taking advantage of all the opportunities that you have. With that, I will give you the spectacular, amazing Angelita. Angela.
Hello, David. Thank you so much for your generous introduction. I'm very happy to be here sharing with this World Society this marvelous event. Thank you for introducing the CLADE, and we have to start with our very best first start. Dr. Emilio Campos, who's in Bologna, and he has been in the strabismus field for more than 45 years. He co-authored with von Norden the binocular vision and ocular motility in 2002. He's a professor and chief of the ophthalmology university in Bologna until December 2018, and now he's lying in his nice backyard, enjoying life and giving his expertise to all over the world. I would like to say good morning for America, buenos dias, good afternoon for Europe, maybe good evening in Asia, and hope our people in Australia, especially our speaker, could be awake for the whole conference. So Dr. Emilio Campos is going to be succeeded by Dr. Ramesh Kekunnaya, our star from India. He's our sapphire from India. He is the head of the Child Sight Institute in LB Prasad in Hyderabad. And we had the pleasure to stay with him in the last World Society Congress in Hyderabad. And he is in the picture with his lovely wife, Akila, one of our best friends in the World Society. So, Ramesh, there is going to be, after Ramesh, we're going to have here from Bern for the University of I can't see the very well, but we have here from Zurich, Daniel Mojon. And could you, David, say something about Daniel? Because I know you know him very well.
Yes, and Daniel has trained in glaucoma, strabismus, neuro-ophthalmology, and I think you'll hear today that's part of the reason how he developed his technique because of his background. He was head of genetics, neuro-op, and strabismology and glaucoma at the University of Bern, then in St. Gallen, and now he is the CMO of the Airport Medical Center in the eye clinic in Zurich, and the part of the University of Bern. He is an artist. He draws cartoons. This is his wonderful family hiking just 2 weeks ago out in the beautiful area of Switzerland.
That makes me very envy because he could be able to be outside, but he will share with us all his marvelous expertise. And here is Dr. Ning Strube. She's the director of pediatric ophthalmology and adult strabismus. Is associate professor in Queen's University, Kingston Health Science Center, the departments of ophthalmology and pediatric in Kingston, Canada. And she's here with her family. And she recently appointed as a school home teacher and a housekeeper and executive chef. And we welcome her, and we hope that we could celebrate her birthday this year together. And here
Greg
we
Donaldson.
have, yes, and he is our speaker from in Australia, and we are hoping that he is awake. We have to run this webinar on time in order that he could get some sleep. Well, he's the head of a strabismus unit in Sydney Eye Hospital, and is director of training Sydney and president of Australia and New Zealand Strabismus Society. And he will be one of our panelists also around.
Angela, I have to share with you that, Angela, that Craig Donaldson and his family hosted me and taught me the game of cricket, which I knew nothing about before I met them.
Oh, I didn't know that.
Yes.
So maybe for the next World Congress in Australia, we could, learn something and to have a game.
That would be fun.
Okay. And here, last but not least, this is David Granet. Everybody knows David Granet, our marvelous host. He's the director of Radnor Children's Eye Center in Shiley Eye Institute and Rader Professor of Ophthalmology and Pediatrics at the University of California in San Diego. So I think we are all now ready to start, David. What do you think about that?
Yes, and I want to share just one thought with everyone. Every morning, you wake up, you have two choices: to continue to sleep with your dreams or wake up and chase them. I suggest that we wake up and we chase them. So now, As we get started, we will be reviewing different incisions. We'll go Limbal, Fornix, and a minimally invasive approach. And during that time, we'll have our panelists and moderators be asking questions and interrupting, and we'll be looking for your questions coming from the audience. So please join us and ask questions. That is your way to participate. Our first speaker is the esteemed Emilio Campos, the keynote strabismus speaker from the World Society meeting that was held in Milan. Emilio, thank you so much for joining us. The platform, the audience is all yours.
Okay, thank you, David. It's a real pleasure to join you all. And I try now to have a share of my video, which is obviously not so easy to achieve. Let's see if I, the idea of opening the conjunctiva at the limbus has been brought forward many years, not really so many years ago, I would say about 30 years ago, by the Decker in Germany, who thought that it was better to open the conjunctiva in the only place where conjunctiva and tenon capsule. Do you see my video now? Is my video seeable?
It's not yet.
You don't see it?
No, you have to share your screen.
No. I put this share the screen.
Now we see it.
Now you see it? Okay.
Yes.
The idea was to open the conjunctiva as you see it here, where the tenon capsule and the conjunctiva are together. Why was this done? Because in this way, the possibility of having a scar later on was reduced, A. B, you had an excellent accessibility to this to the muscle. And C, in the moment in which you open the field, you have the possibility later on, the moment in which you had to put the sutures, to avoid having a vertical shift for horizontal muscle and horizontal shift for the vertical muscle. Obviously, this type of approach is usable only for recti muscle and not for oblique muscle. Because if you would do a limbal incision for opening for the oblique muscle, you would have a huge opening. This type of incision is quite easy to achieve, and it does give reduce, if no bleeding at all, if you properly open the field, and then it creates a good type of scarring for which, in the moment in which you would need to have a reoperation, it is extremely easy to access the area of your recession. Let's see if I can, if you do see another movie. Do you see?
Emilio, you stopped sharing your screen, so we're no longer seeing your video.
Okay. Now you see it?
Yes.
Now you see, this was a re-op, and in this case, it was extremely easy to access the area of surgery without any other type of scarring. Originally, I have to say, I was trained with an opening above the insertion of the muscle. This brought always a very unpleasant type of scarring. And I abandoned it immediately when I had the opportunity of having this other type of approach. And this, by the way, as I say, it was the Decker, the German colleague who died some years ago, who introduced it. And then it was, I understand, used it all over the States and the rest of the world. So that I am very much in favor of this opening, where I use, by the way, do you see it now? Do you see the video now, which I changed?
Yes, we do.
Okay, and in this video you see that the closure of the wound is obtained with 8-0 vicryl suture, which does not give any problem for the patient who has no sense of foreign body after the suture is finished. And then further point is that in this way you have a very flat type of approach, and this has the advantage of eliminating the risk of inducing corneal dellen, which is a very unpleasant type of complication in any type of strabismus surgery. So I'm of the idea that this type of approach is accessible, easy to be performed, and with very few complications. As compared to the possibility of using a Fornix opening, I prefer this one because a real Fornix opening is done in a very posterior part with a fair amount of bleeding. A lot of type of surgeons speak of Fornix opening, but they do indeed not perform a Fornix opening. They just do an opening of the conjunctiva relatively close to the Fornix. And finally, as far as the minimal opening that our friend Daniel Mojon is going to show us, this can have some indication for certain type of situations. So that in conclusion, I think that limbal opening is exceptionally good for recti muscle. Minimal invasive is acceptable for certain type of situation, and a peripheral opening, which is not really Fornix, is an applicable use for oblique muscle, superior and inferior.
Emilio, I was just going to ask a couple of questions, if I may.
Yes, sure.
When we're teaching strabismus surgery, often the limbal-based incision is the one we start with because it gives the easiest and maximal access to the muscle. So the muscle's easy to find, people can understand the anatomy. Do you have any hints about how to teach the trainee to find the muscle smoothly? A number of trainees will bring the muscle hook up in the middle of the muscle. They will get caught up in tendon's capsule. What are your pearls there regarding actually isolating the muscle and doing it cleanly with a limbal incision for the person who's starting off or the person who's training someone?
Well, the idea in this case is in the moment in which you have opened the conjunctiva, is to hook the muscle on both sides. And in this way, you are sure that you are able to then operate on the whole muscle. You don't leave pieces of muscle, as you correctly pointed out, as a possible complication. Then the opening is acceptable enough for cleaning the muscle itself and allowing us to avoid any type of scarring in the moment in which you fix the muscle on the sclera.
Okay. And when you're actually dissecting the muscle off, do you tend to dissect everything off the muscle? Because a limbal incision will give you excellent exposure and you'll be able to do that. Do you tend to dissect everything off? And if you do, how far back do you go? Do you take off the ligaments as well? What do you do?
Well, I usually cut the ligaments as well and try to have as a clean muscle as possible in the moment in which I prepare and put the sutures for then fixing the muscle on the sclera. In this way, I have to say that also in the moment in which I, as it happens, need to reoperate on this muscle, I have the least amount of scarring.
Mm-hmm. One of the things I think we're looking at here is looking at the various ways in which we can approach strabismus surgery with a minimum amount of scarring and also a minimum amount of inflammation post-operatively and comfort for the patient. Really, that's what our aim is, I think, in doing these different incisions. When we do this and we look at the studies involved with it, there's very little which actually tells us about what suture material is used. You use an 8-0 vicryl. Here in Australia, we're still able to get fast absorbing catgut, which tends to be very comfortable and dissolves away within a week. I know that's not available in other parts of the world. But the other things I think that are important are probably your post-operative regimen of steroids or antibiotics. Do you use steroids routinely post-operatively with these limbal
Yes,
incisions?
I would like to make a couple of points. The first one of the main issues is I try to avoid, even if I have a little bit of bleeding during surgery, to cauterize, because cauterizing the muscle is responsible of a lot of scarring. And in fact, if the patient is normal with a bleeding situation, there is no risk that the bleeding will go on. As far as a suture, I presently use Vicryl 6.0 for any type of muscle approach. And I used to use CatCut, but CatCut had two problems. The one, even if the cases were very limited, we had some reaction to CatCut with cysts that I don't see anymore with Vicryl. On the other side, the CatCut itself, as you correctly point out, it dissolves very, very, very shortly, in 1 week or maximum 10 days. And this, in some cases, may be dangerous, especially if you operate on the inferior rectus muscle, which is one of the most dangerous muscles, as everybody knows, where the lock ligament is open, and if you lose that muscle, you are in real pain. So that's one of the reasons for which I abandoned several years ago CatCut and use Vicryl exclusively. I obviously use non-absorbable sutures in case of tucks and of myopexis of the muscle. That's another issue.
Dr. Campos, I have a question for you. So you may be operating on reoperations that are done very well, but some of us get operations where there's so much scarring anterior to the insertion that it's quite difficult to approach with the limbal incision, no matter how carefully you try and dissect between conj and sclera. Do you have any tips for that, or do you still proceed with a limbal incision, or would you convert to a Fornix when possible?
Well, I have to say, I did not point out at the beginning that I moved to using the microscope about 12 years ago. And so I exclusively use a microscope for doing strabismus surgery.
And why did you do that? Why did you switch to the microscope?
Well, I'll tell you why. I used loops, and I had all the Zeiss loops, which worked perfectly. But then I moved to another operating theater in my department, in which I bought an excellent microscope, a Leitz microscope. And I said, let me try it out, how it works with this type of approach. And I have to say that as far as these problems that you correctly pointed out, the opening of the conjunctiva and localizing oblique muscles, both superior and inferior, with a microscope has changed my life. And I have to say that whereas at the beginning it took me a little bit longer time to do the procedure with the microscope, now I can say that the timing is exactly the same, having the advantage of A, localizing extremely well the muscle, B, following exactly the needle during the suture in order to have an idea of how deep you enter the sclera.
Thank you.
There was a question which was raised regarding actually isolating the muscle. Now, some people will use a cotton bud just to clear all the tissue off the muscle, and other people will dissect it carefully with scissors. What's your view on that?
Well, my view is to it depends on the age of the patient. In children, I would dissect carefully. I use Westcott scissors and dissect carefully without obviously creating lesions in the muscle. In adult, and now I have to say, the patient populations that I'm operating on now has moved incredibly, for which I would say 70% of my patients are adults who have subjective problems like diplopia, torsion, and whatever, which are not treated usually by doctors. But in these cases, it is enough to use a cotton to clean up the muscle, because there is not a very strong adhesion of the fascia on the muscle itself. And so you can very easily clean the muscle with a cotton. in adults. And the older they are, the easier it is.
It's interesting that it was said that with the reoperations that you find the Fornix incision easier. I actually find it just the opposite. I remember operating on a patient who had 21 previous strabismus surgeries. I don't know if that's a world record, but all the notes were there. They were in various countries by various ophthalmologists. And I had no idea where the muscles were. And the philosophy was just the same, to sort of start somewhere where you know where the anatomy is and work your way backwards. I don't know if anyone else agrees with that, but I must say I tend to find a limbal incision useful for those patients who have either had trauma or numerous surgeries, whether that's traumatic or not. But I think that the Fornix incision in those patients I find difficult personally.
By the way, we have to recall that retina surgeons, in the moment in which they do they prepare an encircling procedure, they do practically what we do on a limited amount of the corneoscleral border. That is, they open the conjunctiva all around the cornea, and in this way they are able then with two sutures to close the conjunctiva. Have an excellent exposure.
Emilio, it's David. We're going to see surgery by Ramesh and by Daniel that shows very small incisions and limited view of the muscle sometimes. And they'll say that it's better to have the smaller incisions. The incision you showed looked big, but you still closed with just 2 sutures. How would you compare having the larger incision and better vision of what you're doing versus smaller incisions and maybe not see as well?
Well, I have to say, particularly if you are not a great expert, the large incision obviously is much better because it protects you from making any type of mistakes on one side. On the other side, I have also to add that whereas originally I tried the Fornix incision, and I gave them up essentially. Whereas, as I say, I do in limited cases use what Daniel is proposing. In the other cases, I see no reason for me to be saving in an opening of the conjunctiva, because as a conjunctiva, if you are able to just close it with 2 sutures, as I showed you, has never given me any problem. The only problem you can have is what happens sometimes when I had residents do surgery, is that instead than suturing conjunctiva with conjunctiva, they suture conjunctiva with tenon. This is something that you really don't want to deal with because it doesn't give you a good scar, and you are obviously always obliged to reoperate in those cases.
And we have a question that came from the audience that asked you to describe the difference between the incision that you showed and a swan incision.
If you consider the swan incision an incision which goes above the insertion of the muscle, I would say that in that case you can have an excellent exposure. You have on one side, but you have a scarring as a signs of which will stay on for the rest of the life of the patient. And the plica semilunaris will be very often moved in a not wanted direction.
Wonderful. And when you closed the conjunctiva, was that buried knot?
No.
Or was that a surface knot?
No, a surface knot. Very simple.
Okay.
And it doesn't really, the 8-0 micro does not, I've never had really patients being disturbed by this. Answering to what Craig said before, my attitude after this type of surgery is obviously I don't occlude the eyes after surgery. I leave the eyes open. And I prescribe about 10 to 15 days of drops with a mixture of steroids and antibiotics. The steroids are very helpful because they help in reducing the inflammation and the redness of the eye. The antibiotics are used as a prevention of a possible infection, but I really don't know whether they are necessary.
I use
very proofs, real proofs.
Yeah, I use Ado also, and I find that it's extremely comfortable, and versus cat gut, which tends to be larger, and my experience is a little less comfortable. Craig, I was wondering what your thoughts are.
I think that the cat gut's more or less gone by about 7 to 10 days, whereas the vicryl tends to stick around for weeks. I was going to ask the question of when you're happy to remove the vicryl that's irritating the patient.
The Ado vicryl doesn't stick around that long. And I use a buried knot and a Fornix incision, which we'll talk about, but it doesn't cause any of the kinds of problem that you described.
I'm with Craig. We use the 6.0 plain gut at my institution, and I had a patient who swore they were allergic to vicryl. I don't know if that was true, but we did one eye vicryl, one eye plain gut. She was much more comfortable. The sutures seemed to get a lot softer. Neither of them were buried. I've tried buried before, and I think that probably helps with a bit of the comfort, but it takes a little more time to teach the residents to do that.
How interesting. And I just got informed by one of the people listening on YouTube that they're discussing whether or not they use the microscope or they use loops. And I can tell you that was one of the incredible experiences I had at the World Society meetings, the First World Congress, is George Ellis from the United States asked that question of the audience. And in the audience, almost 3/4 said they used a microscope, whereas in the United States, most people use loops. Online, they're saying it's about half and half right now using microscope and loops. So in our field, we have a significant split in the approach to just even visualization of the eye during surgery.
So David, which one do you prefer?
I'm getting old, and so I use what I was taught with, and that was loops. I also operate in an operating room that has a microscope for the other surgeons in our eye institute. I have been, I think, finally convinced to try to use the microscope. I'm curious for the trainee if people feel that a microscope or loops are better, and if a limbal incision is better.
Now I can confirm that I am younger than you because I was trained by microscope, you know?
Thank you. I appreciate that, Angela.
No, David, friends, I've had several years of experience with the loops. And as I said before, I moved to the microscope about 50 years ago, and I trained all my residents with the microscope. So all my residents for the last 10, 15 years have been trained with the microscope. And I have to say that I didn't find for them any major problem in approaching this technique. And I have to say also that this type of scarring you have and the closure of the conjunctiva and a lot of other aspects improved for me in the moment in which I use the microscope. A small adding point is also in the moment in which you want to record your surgery and you do it with a microscope, it's much easier than recording it as you were used before. You had to have special systems which were able to show you an enlargement which was not easy to achieve, so that you could then film your surgery. Now with a microscope it's very easy.
David,
So
I was going to say, sorry,
ahead,
David, I was going to say that with the microscope, one of the things I found useful with the trainees is they find that their field of view is so small, is to make sure it's on minimal magnification, and that tends to sort of help.
So you
You're
make
right.
the microscope work like loops.
Almost, yeah.
Okay. I think it's really interesting and something that I need to add to my repertoire. As we tie this up, we're going to move on to explore the Fornix incision with Ramesh. Ramesh, is this a good time to do the questions that they have for Blueberry? Ramesh? I'm not sure Ramesh is hearing me. Ramesh, is this a good time to do the questions?
Yeah, I think we can go with the presentation and then take some more questions. There are 30 questions on blueberry, so we can take it after this.
I was thinking of the polling questions that
polling
we have.
Question maybe we can take after Daniel's talk.
Great. Okay.
Okay. So, Ramesh, please, we are ready for you.
Thank you, Angela and David, for the nice first discussion on the Limbal. So what we are trying to do is the eye moves in a different direction, and we are looking at to reach that muscle, what is the best technique, what we can take. Each have their own advantages. I personally favor the Fornix based. In the literature, actually there is a confusion. Fornix based is actually a Limbal. The base goes to the Fornix, and Fornicial incision is actually Limbal. So I'm not going into the controversy of that. I always start from the Fornix. When I say always, it's almost 90 to 95% of the cases, I go Fornix route. 5% we can probably in the discussion, I will come back. With regards to microscope or loop, I use loop because again, we can talk about why I do use loop, what are the advantages, and all of us can switch to microscope as well whenever it's required. So that we will leave it. I will, David, show the first 5 slides, and this on the 6th slide, the video will be running. We can go into questions afterwards. So the first one, Dr. Campos said that Fornicial surgery leads to a lot of bleeding. It's always best to use some hemostatic. I generally use brimonidine, 1 drop. You can see how the eye blanches. And always when you really start your incision, avoid small conjunctival incision, conjunctival vessels. That really helps in most of the patients. As you can see in this video, it's a quick video showing the lateral lectus incision. I am avoiding all the vessels there. Initially, it's a good thing to measure, and then you can go on to, you can even see the insertion when you move the muscles. In the primary surgery, you can even see the insertion of this. Some of the repeat surgery, we can go forward. I use the fibrin glue of late. Earlier, I used to use polyglactin suture, and this fibrin glue acts as an adhesive, and it's quite good for the conjunctival closure. One thing I wanted to say, if the patient's age is he's really old, he or she, I use this cotton tip just to rotate the globe, because I generally use Moody's forceps, except in older people, where I use this cotton tip, because the conjunctiva there is no tenance at all. Once you cross 50 years, the tenance is almost nil. So if you use Fornix incision with the Moody's forceps, wherever you apply the Moody's forceps, the conjunctiva tears completely there. And
Ramesh, did you, I'm sorry to interrupt, but I think I just heard you say that you don't use the Moody forceps on the really old people, and then you indicated that was, over 50?
Yes, that's the fragile conjunctiva.
Wait. No, stop. I'm sorry. Really old is over 50?
I'm not getting into that controversy. I'm not saying who is old. I'm just saying more than 50.
I will talk to you later on. Yeah.
Okay.
You just aged all
David, you're muted. Anyways, so this is the post-operative picture of that. And David wanted me to show some of the different instruments what I use for tight muscles. This is one of them. I used Kowal's hook. This is Lionel Kowal's. He designed it. This is a simple one where You don't need the assistant to pull it. In a tight situation, you can use it. You can even pass the suture. Even when I perform topical anesthesia strabismus surgery, I use this Cowell hooks, which is really, really useful. Now, for the first 1 minute, I will show you a recess resect. These are the instruments I use. I don't use microscope. I use loop. The Moody's forceps and the tissue retractors are very, very important. We can begin. Any questions are there? This is the recession. You can see this is the Moody's forceps. I start.
Ramesh, you have.
Yeah,
I see 3 hands. I see 3 hands there. Does that mean you have an assistant?
Yes, always. That's the disadvantage. For this, we need an assistant always if you want to do this technique, because you're seeing that this is pulled by one of the assistants, either a staff nurse or this step.
Ramesh, I'm sorry, but this is not Fornix. It's closer to the corneas than the Fornix.
Dr. Campos, it's just at the insertion. You can go to the upper pole of the muscle.
But this is not really Fornix. It's not really Fornix. Because the Fornix would be farther away. It would be where the 2 conjunctivas, the lid conjunctiva, the bulbar conjunctiva, just across.
Okay. Then I'll put it as modified Fornix, which is even better because the size of the Fornix will be small. The incision will be smaller. You can see what I want after the disinsertion is I want a rectangular area there. The Moody's is pulled. I can mark the muscle there and then suture, pass the suture, and then continue it. And I use the same thing for the resection as well. I will forward the video. Yeah, similar thing has been used for the resection. So the teaser hook and the hook is very, very important for this. This is the incision, just the width of the muscle. Right. In the initial period of training, the fellows go a little bit larger on their incision, but as they get more and more experience, the size of the incision becomes less. So that's the technique. Any questions at this point of time? This video will run as we are discussing many of the techniques which can be shown. I have some resurgery as well, vertical rectus surgery, and even oblique. So if you have a 10 or 15 minutes discussion, we can begin.
How many millimeters from the limbus do you actually open the conjunctiva?
It's, if you ask me a number, it's 8 millimeter, but always
from the limbus. No, from the limbus or from the insertion? Because the insertion is about 5.5, 6 millimeters. And your opening is behind this, obviously, right?
If you ask me a number, it's 8 millimeter, but it varies what muscle you're tackling. Like with the Moody's, you can move the globe, you can see the ciliary vessels. I'm talking about in primary surgery, you can go to 5.5 or 6 millimeter for medial rectus. It can go up till 8 millimeter for the lateral rectus. I don't measure, but generally speaking, around 8 millimeter is a good number.
Ramesh, can you take the video back to exactly the beginning where your incision is?
Absolutely.
But it's not a Fornix incision, in my opinion.
Dr. Campos, Ning here. I think you make a really good point, though. What we're defining as Fornix is I do similar surgery to Ramesh, and I specifically tell my trainees, don't go too far posterior. If you were to go where actually the true Fornix is, you're going to start getting into fat and really run into trouble. So I agree with you that that's not where the incision should be.
Okay. Well, now once this is clarified, I'm happy.
So if the lateral rectus is 7 millimeter from the limbus inning, we have to go a little bit behind. That becomes around 8 millimeter. We can't do for the lateral rectus. We can't do 5 millimeter. If you are dealing with the medial rectus, yes, of course, you can go 5 or 5.5 millimeter. You don't have to go 10 millimeter or even 8 millimeter for the medial rectus.
I mean, I'm like you. I say about 8 on my dictations. I never measure, and it's looking at the ciliary arteries, and each eye will be slightly different.
Yeah.
Ramesh, I think the classic Fornix incision would have also been inferior to the medial rectus more than you do. You're closer to the muscle,
this is what the examination of the muscle before the surgery. In the primary surgery, it really helps, because as you go closer, you can reduce your size of the incision. That's the advantage. But at the beginning, that's what exactly I said. At the beginning, the fellows and the residents, they go a little bit down compared to this. I go as close as possible.
Ramesh, I had a question about. Sorry, I had a question about your comment of using fibrin glue for the Fornix incision. I've used fibrin glue to close the limbal incision if I'm using a technique that Ken Wright and I have talked about using a hangback with glue, and that lies that conjunctiva down very nice and flat, like Dr. Campos described. The Fornix, do you not find that there's still a lot of tenons and it's a bit wet? Like I've not tried it with the Fornix, but my understanding is it can be a little trickier that actually closed.
Yeah. Eating, what I do is have to avert both the conjunctiva. You have to hold the edge of the conjunctiva, avert it, dry it with the sponge. When you avert it, make sure that you don't have the tenons there. That really makes it very much conjunctiva to conjunctiva. These two small additional things, you need to do it. Fornix, I don't close the medial rectus incision at all. For the superior rectus, inferior rectus, lateral rectus, I use this technique off late. It gives quite good results.
So when I close my Fornix incisions, I actually do what I was taught in fellowship. I close the tenons first as one layer, and then I close the conj. And I personally would never leave an incision open for fear of setting yourself up for infection. So
I'm sorry. So you have sutures on 2 layers, right?
Correct.
So tenons and conjunctiva.
It takes an extra, 10 seconds. Just quickly close that tenons. It prevents it from getting into that conjunctival incision, kind of like what Ramesh was saying with the glue. And I would find that would be less finicky because the tenons can be quite sticky. Trying to push that out just with cotton tips and glue. I could try it and see.
Ramesh, there's been a number of papers about fibrin glue. There was one in 2013, I think, in ophthalmology, and it worked well, but there was a number of wounds which actually needed resuturing. Did you find that to be an issue?
Yeah, we are currently doing a prospective study. The resuturing rate is very minimal, around 2 to 3% in my experience. So, the more than the success, even in when you suture also, there are some cases we need to do resuturing because sometimes the vicryl gets just dissolved and it goes off. So more important is it's expensive. If you don't have a pool of 5 or 6 cases, it's expensive. The fibrin glue is expensive. So that's one of the factors we need to consider.
Just a very basic question too, just watching your surgery there. Some people are taught to do partial thickness bites of the muscle. I've never been an advocate for that. Do you ever incorporate that, or is that taught, or is there any feelings about that?
I take the central bite as partial thickness, and the side bites both will be full thickness bites because the side bites, the locking bites, keeps the muscle in place. The central one is to prevent any kind of sagging. Like I am advancing this muscle, I want the whole of the muscle to spread equally. I use that central thing. So this is an advancement here you are seeing. So I use that technique. I don't know whether others on the panel use a different technique.
I use the central security knot, full thickness, and I do definitely the full thickness locking bites at the pools. Ramesh, you brought up 2 other points that were really good, again, for sort of trainees. You mentioned using the cotton tip for the conjunctiva. I do that for my limbal incisions as well, sort of a no-touch technique, because as that conjunctiva gets more fragile at an unspecified older age, that can really help when you're rotating the globe. And then I also like that you showed the grooved hook. That's a huge benefit, just for safety and for those tight muscles.
Yeah. And additionally, when I tackle the vertical rectus muscle, I cauterize that ciliary vessels, because vertical, in my experience, the vertical rectus muscles bleeds a lot compared to medial rectus or lateral rectus. So that's the additional thing I use when I do a superior rectus.
Ramesh, from online around the world, apparently people are saying that they think you will have really a swan incision more than a fornix incision, and that you've cheated a little bit towards a swan rather than the classic fornix incision.
Okay, I would not agree with that, David. Respectfully, with whoever has said. In swan, what you do is you go across the muscle, not exactly across the muscle, just above the insertion, you go 1 or 2 millimeters. Here, what you do is either at the superior pole or the inferior pole of the medial rectus, or whichever rectus muscle or even oblique muscle, you use this teaser hook to go over the conjunctiva. If you cut there, your incision size is going to be much more. We do cut swan, we do cut. In this technique, we don't cut. You can see on the videos, we use that teaser hook to go from retract the conjunctiva. So that's the difference. And the swan incision is much longer than this, which I use in some of the cases of resurgeries. But I still think this is Fornix incision.
Ramesh, let me ask you. I see you never use fixation suture, traction sutures, right?
Never, Dr. Campos, never.
Never. You don't. You are not helpers. And then let me ask you. You show a myopexy. Which type of sutures did you use for the myopexy?
We use Dacron, non-absorbable Dacron suture.
Okay. Thank you.
So, Ning, on YouTube, apparently there's a discussion going on, and none of the surgeons of the nearly 300 on YouTube have said that they closed the tenons. So I'm sure that doesn't surprise you, nor can, but Dr. Wright in this case, but I just wanted to pass that along.
Yeah, I mean, I don't think it's necessary. I think it's probably most useful in our younger children who have so much tenons. The idea is just to allow that globe to rotate nicely. Obviously, in a lot of the adults, there's almost no tenons there to close. I'm not surprised. It's just another technique, especially if you have tenons coming to the wound. It's a helpful trick.
Great.
There's a question from George Ellis. I don't know if we can have on the question board. He's asking Ramesh, when you make your incision, do you make a separate tenons incision? Because we know the chondral stretch and not the tenons. And what direction do you make it in? And I think this is a good question because I have colleagues who make one incision through conj and tenons at the same time. I know I make my conj incision and then a perpendicular tenons. So maybe an interesting thing to bring up.
Yeah. Thanks, Dr. Ellis, for that question. I just go directly onto the bare sclera. That's how I do it. I don't go layer by layer. In the Fornix, you will have to go directly onto the bare sclera, because if you leave some tenons there, your hooking of the muscle is going to be real difficult. That's what is the main problem. So I don't have two incision. I directly go on to the bare sclera.
So
Ramesh,
Craig, this is, let's take this last question, and then we're going to move to our final incision.
Okay, Ramesh, there's been some work suggesting that a recession of a muscle with a Fornix incision is not equivalent to a recession of a muscle with a limbal incision, with a greater bang for your buck with a Fornix incision rather than a limbal incision, because perhaps of a dragging effect of the conjunctiva. Has there been any sort of Do you have an opinion on that? I mean, do you think that that's real?
Yeah, I haven't compared head-to-head, Craig. Only thing I can see is, obviously, as strabismus surgeons, we have a lot of resurgeries. When I go back, I don't see any difference. To give an evidence, I don't have a head-to-head, but I don't think so, because at the initial part, I used to really clean up the muscle almost 10 or 15 millimeter behind. I never do it anymore. I just cut the tendons and other tissues just at the insertion and do it. And all of us, I think, can come to a conclusion looking at our resurgeries. With that, we can make a thing. I wouldn't think it will make a difference, but I don't have evidence to show what is the difference.
Thank you, Ramesh, for your presentation. And I think we're going to move on, David, for Daniel Mojon. Are we ready for do that?
Yeah, Daniel's been suspiciously quiet, and it worries me when Daniel is quiet. I think he's laughing at these incisions and wants to tell us why there's a better way. Daniel, the platform is yours.
Daniel is going to talk about minimal invasive strabismus surgery. And okay, Daniel, please enlighten us.
Well, thanks so much for setting up this great meeting. I'm saying hello to everybody. I'm not laughing at all. I just thought, well, most of the things have already been said. So that's why I thought I wait. So I'll first start quickly, briefly, how I became a squint surgeon. So I was first a glaucoma and cataract surgeon, and unfortunately the guy doing squint surgery in Bern at the University Eye Hospital quit it quite early. He was planned to stay many, many years. So I had to jump in at the deep end. Fortunately, I had Lang, who was in Zurich, who bailed me out, you know, because just I did some muscle physiology and 1 year of neurology, but that is not entitling you to do squint and run a department. So fortunately, I had Lang, and I'm very grateful to him. So I came already using the microscope and used to enlarge quite a lot. And I was I learned with the loops a limbal approach, because that was the classical approach as well. And I was very happy about that, but very soon I switched to what many people call MAS, so microscope-assisted strabismus surgery. And I felt like Emilio, and thank you for sharing your experience in that. I felt just I see much better what I'm doing. That's why very early I switched to the microscope. Then I went to the United States and I was confronted with Fornix incisions. And I had to admit that at least in cases where we had to deal with complications like more swelling, a bleeding, the limbal approach wasn't really the best approach. We had to deal with a lot of Delven, clearly in only such cases. That doesn't make the technique bad. I think a nice limbal opening with a nice closure is a great technique. So when I came back, I did a lot of Fornix incisions, and because very early, I was quite young, but I was starting getting already one of the older guys doing squint surgery. This had a big disadvantage. I started getting very early quite a lot of repeat surgeries. And I wasn't really feeling happy neither with Fornix incisions nor with the limbal approach, mainly for repeat surgeries. That's why I tried to have a new approach. And this was this approach using 2 small incisions. And I'll show you now, I'll share with you a video showing a repeat surgery. This is a very advanced case. Advanced surgery you should do only if you already did quite a lot of surgeries, but I will tell you some, I will give you some tips how you can do repeat surgery with MISS technique when you're not so experienced after this video. So I'm starting here, and I'm now going to share the
Daniel, yeah, you have to share your screen and turn the sound off.
Yeah.
Share your screen and turn the sound off.
The sound goes off now, and I will now share the video here. So you will see first the traction suture. This is a Prolene 6.0. That was another issue. I didn't have an assistant, or I wanted my residents and fellow to see patients. That's why I had to come up with a technique where you don't use a assistant. So this is a repeat surgery where I advance a previously recessed medial rectus muscle. I'm hooking with a small hook, and then I'm going below the muscle with a spatulum. And so the needle now will be first between the muscle and the spatula. And now I go through with a safe way because you have the spatula protecting. And now I'm going with the spatula in the space between the conjunctiva and the muscle to retrieve the needle. Clearly, these are things you have first to do with a larger opening to ensure how much tissue you have to take. This is a full thickness bite I'm taking. On this side, I'm showing a little bit of more advanced technique. You're wondering I'm taking quite a lot of a muscle, but that's not true. If you then pull back the needle as shown here, you will realize that it's about 1/3. If you pull back the suture, when you're in the space between the conjunctiva and the muscle, now you're able to do a second suture at the other end of the insertion without displacing the conjunctiva a lot. This is a Vicryl 6.0. I have even one that has a smaller special spatula needle done for me for small incisions. Now I measured the advancement distance, and I'm already fixing the suture there. Here also I'm measuring the advancement. It's quite a small one. It was 3 millimeters here, because here was only, the consecutive XT was quite small. Now this is a crucial moment to cut the muscle without cutting the suture. And with time it's rare, but when you start, you'll cut the suture, then you'll have just to redo it. But usually you're not going to cut both. Now I advance the muscle, I just tie the suture, and if the incisions are very small, I usually don't close them, but if you want, you can also close them with a, I'm also using Vicryl 8.0 sutures. Yeah.
Daniel, when I cut a muscle, it usually bleeds. How did you do that?
I have a bipolar monoaxial diathermy probe that I use for glaucoma surgery. That is very nice. You can go in and you have the energy. It's with the by the pedal. You can just very nicely choose the energy that you want to apply to ensure that you don't damage the muscle. So here I closed, and clearly not always, but frequently I have repeat surgeries where you don't, where I,
this type of surgery, and we'll be ready for questions now. Thank you for your time.
I think now the video is stopped.
Daniel, I want to follow up on Craig's question because I didn't actually understand your answer. The scissors that you're using when you cut are attached to are effectively a monopolar when you're cutting the muscle?
They are the scissors themselves. these are Westcott scissors, absolutely normal ones. I haven't shown here because it wasn't bleeding. There is a special probe I'm using. It's a very thin, about 2 millimeters thin probe that is monoaxial but bipolar, where you can go in wherever you have a bleeding and stop it.
Then do you use this also for a recession, this approach?
Absolutely. I use the approach for all part 1 indication. These are huge scars that occur between the superior obliquus and the rectus superior muscle, the superior rectus muscle. I always say these are the superior oblique shouldn't be operated by somebody who has not a lot of experience, because this is, in my experience, the hardest type of surgery. If you get scars there, usually depression is strongly decreased, and these are surgeries that are extremely difficult to do through minimal openings. Maybe I can say some general things about the different methods we are talking about. I don't believe there is one good method. First of all, we have to look, is there a microscope around or not? Can we use an assistant, yes or no? How skilled is a resident, and how much time do you have to teach him maybe before he leaves? Then important, I'm not talking about that right now, but how to take the plunge. So you should start with I can briefly say, we should definitely start with 2 very big incisions close to the rectus muscle. Because for somebody opening at the limbus, like you, Emilio, the difference will not be so big. You just leave the conjunctiva attached at the limbus, but you make 2 openings on the side that will be a little bit more posterior, and you will notice that just avoiding the limbus will already be very positive for the patient, but you will not need to change too much your technique. And for the Fornix people, the difference is also not so big. You're making your Fornix incision smaller, but the second one on the other side. So this is a very nice way to start. I would say these are big, small incisions.
Daniel, the limbal incision is circumlimbal. The Fornix incision is circumlimbal, but yours is radial, right? You're making a radial incision rather than a circumlimbal incision.
That's
so
correct.
Immediately that's different. Do you think that changes the comfort at all? Do you think that has anything to do with the direction of the incision? Because it's perpendicular to what a circumlimbal would be, essentially. Either I stumped you or you can't hear me.
Well, maybe I can say something if he's not saying. I prefer the radial one because I can, the vessels are usually radially, and if I don't cut in an oblique way, I can avoid more bleeding from the conjunctiva. This is my personal experience, why I prefer the radial openings.
If I may, if I could just ask each of the speakers, just from a trainee point of view and from a strabismologist point of view, Daniel, start with you. When would you definitely not use a minimal incision technique?
Whenever somebody is not convinced that the surgery performed below is perfect, meaning no sagging of the muscle, no injuring of the sclera. So this is really crucial. Whenever you have the impression there is any risk or you're not doing a perfect surgery, you should open when you start with 2 small incisions, convert even to a complete limbal opening. That's always possible, but don't take any risks for the patient, please.
David, Angela, I don't know if I'm allowed to do this, but if I could switch to Ramesh and ask him the same question, when wouldn't you do a Fornix incision?
Thanks, Craig. Again, I would do a non-fornicial incision. If I'm not doing Fornix, then I will go paralimbal. I never do limbal because it might lead to loss of stem cells and all that. In cases of severe scarring, especially in repeat retinal detachment surgery or some kind of these kind of situations, or if somebody has torn the conjunctiva, especially in elderly people, then I will convert that into a limbal. These are the 2 situations I will use non-fornicial incisions.
If I may,
and I guess, Emilio,
yes.
The same question to you. And the question, it's often raised, the problem with stem cell failure at the cornea. Emilio, you would have performed so many limbal incision strabismus operations. Do you think that's ever been a problem?
Well, I have to say that even if this is from a theoretical point of view a problem, I've never seen this type of problem occur using limbal incision on one side. On the other side, I have to add that I feel that major damage could occur in adult patients by not using a limbal incision. At the moment in which you don't use traction suture, in patients who are, I would say, speaking with David, I'm not speaking of 50, I would say 70, 80 years old, in which, for example, surgery is nowadays, in my hands, quite common, in which I don't use traction suture because I'm afraid to tear the conjunctiva with a traction suture, and the way in which I move the eye to open the conjunctiva is just to put a hook in the opposite direction of which I want to move the eye. In this case, a tearing of the conjunctiva is much more limited by using a limbal than by using a Fornix or pseudo-Fornix incision. Again, the possibility of inducing nutritional problems to the cornea after limbal incision, something which has never really worried me, and I've never had this problem. The only problem I've had is when the limbal incision was not properly performed, and you could have Bellen develop in this patient. If this was the case, certainly that was, in my opinion, more the fault of the surgeon than of the patient.
A question that's come up on YouTube, and apparently there's a very robust discussion going on amongst the hundreds of doctors listening in on YouTube, was, Daniel, one question for you was, does the miss sag? But which brings up the question of, when people are used to doing surgery one way, they have the amount they'll recess a muscle or move a muscle. If they try one of these other techniques, do they have to start changing those amounts? So switching from limbal to Fornix, or Fornix to miss, or miss to limbal, do you then alter how much you move the muscle for each deviation?
This is a very important question, and I'm still completely amazed that you don't need to change your dose response relationship. And I was very worried when I changed, and I have now so many people that I trained and they switched and they're confirming. So my first study included 1,200 cases performed with miss and limbal approach. And fortunately, even in the subgroups, of different muscles, we couldn't find the difference. And this is really amazing because dissection is really limited with small incision. Maybe I'll add just one short thing to the traction suture. I'm coming from glaucoma surgery. I had to learn to do a traction suture that is not touching the conjunctiva, because glaucoma patients are all old patients, or the majority, apart from congenital ones. So I'm really doing a corneal traction suture apart in children, where I like to be even in the sclera to be able to rotate the globe better. You have to be careful. If it's too superficial, the suture will not hold. What happens is you have a small, you injure very in a small place the cornea. This will usually not have any influence on your outcome. If you're really too deep, you can get a filtering bleb that is unfortunately not working. If you see that, just go out quickly with your suture and do a second corneal suture. So, but you're completely right, Emilio, doing that in older people will induce a lot of problems. You have a tearing of the conjunctiva as soon as your traction suture will go into the conjunctiva.
If I may add one question about the vascularization. You all know that there was so fashionable for a while to try to save the vascularization of the muscle by prolonged surgery and leaving all the vessels untouched, possibly, because in this way theoretically there was not a risk of an ischemia of the anterior segment. Now, obviously, the moment in which you open the conjunctiva, you also induce changes in vascularization. I have to say that in my experience, I've never had any problem. And I never had, honestly, really ischemia of the anterior segment, even by touching several muscles. So I want to have your idea of the other participants on this issue of whether the type of opening of the conjunctiva has some role in the vascularization of the anterior segment.
I did a study on that has never been published. We looked at many parameters. We measured the endothelial cell loss. And I can tell you, you're absolutely right. I couldn't find any difference. So personally, I believe there is no real difference. Whatever approach you have, for the limbal stem cells.
Another question that's been coming up is it possible to discuss adjustable sutures? We haven't brought that up at all. Are any of these techniques better, worse, or more amenable, less amenable, or does it not matter for adjustable sutures?
Well, maybe I can say something about MIST. This is something really very, very nice. If I'm not sure, mainly in repeat surgery, that's the majority of cases where you're not so sure about the outcome. I try to overcorrect the patient whenever I'm not sure, and I'm using a lot of combined surgery, meaning I'm making a recession and a plication, so a muscle fold. And to open such a fold at the slit lamp, starting age, I would say 13, 14. In children, it's impossible. This is something very nice you can do at the slit lamp. So after instilling some topical eye drops, I take a cotton tip. I also put some local anesthetic drops on it, and then I put it really at the minimal incision that has no conjunctival closure. So I open it then, and then I'll have immediately access to one of the two sutures that holds my plication, and then I can open one or two. If I do a very large or very large amount, I even do twice a folding of this muscle that gives me 4 opportunities to open it. And this is, in my hands, a very nice way that works in 9 out of 10 of patients, not in all adults, but in 9 out of 10 patients. And this is great because the patient is sitting there having double vision. You do it on the slit lamp and you ask the patient, is it fine? If it's not fine, maybe you'll open a second one. And this is, in my hands, a very nice way to combine adjustable suture with minimal openings that are exactly where your sutures are.
Dr. Mojon, what do you mean by you double the plication? Can you explain that?
Well, once I came home and I explained to my daughter that I found out that instead of doing 8 millimeters, it's better to do twice 4 millimeters. And she said, well, I learned a long time ago at school that twice 4 is equal to 8. And I felt really bad.
Are you doing
so
I'm at the same time?
I'm just doing twice the folding. Instead of doing a fold of 8 millimeters, I'm doing twice a fold, one over the other one. Some people were afraid that this will give a swelling of the conjunctiva, but not at all. And it's also helpful to do that if you have very large amount. You have maybe a 6-nerve palsy. Sometimes you can fold 12 or 14 millimeters, but to go through a small incision in 14 millimeters is nearly impossible. But if you do 6 or 7, you fold the muscle, and you do again 6 or 7, you can do large amounts. And it's also an advantage to, or a technique, it's called double folding, has also been published, to help you do large amounts of foldings.
If I can add something, I use the adjustables just for a recession, not for a strengthening of the muscles, that is plication or resection. And in those cases, I do use this type of minimal opening of the conjunctiva that Daniel has shown, because it is very extremely useful. And I always try to overcorrect during surgery so that I have to reduce the effect by pulling the muscle, because doing the contrary is extremely difficult.
I just have a question for Ramesh. I do a lot of adjustables, and I do them with resections, recessions, advancements, and so forth. What sort of incision do you use, Ramesh? Do you use still a Fornix incision? If you do, how do you go about advancing a muscle?
Yeah. First of all, I don't do much of adjustable surgeries. I do a single adjustable in a topical anesthesia surgery. That's the only place I do adjustment. I do use Fornix incision. In a repeat surgery, if I have to advance the muscle, I showed on the video, I again use the Fornicial incision.
Wonderful. We have asked all of our participants to fill out a survey when they logged on. Todd, our hosts, can you please show the results of the survey now? I think I said the magic word, now.
It's supposed to be. Maybe we could say another one. Could you please show the survey results? Okay.
All right.
Well,
so what are the other questions that came up? And I'll make this our last questions because it's come up online, which is how you do anesthesia.
Topical anesthesia for Ramesh is a question. If he used any medication or subtenon.
Yeah.
Like a subtenon injection, please.
Topical anesthesia in selected patients, you need to do a Q-tip test, in the clinic to make sure that these patients are fit enough. I don't do topical anesthesia for repeat surgery. For primary surgery, I do it. I apply topical eye drops as well as gel 3 to 4 minutes before surgery. I do not use any kind of subtenants. I don't drag the muscle because only time when the patient feels the pain is pulling the muscle into, with the 2 hooks. So I use Kowal's hook there, and I do surgery. So how many patients of my patients get topical? It's very minuscule. 5 to 8% of the patients can get topical anesthesia surgery.
Daniel?
I'm using topical anesthesia like Ramesh, mainly in primary surgery, clearly in adults. But personally, I don't believe it's enough. I usually give some topical anesthetic after applying the 2 small openings next to the muscle. But be careful, if the openings are small, you should inject a very little amount, because tenons will swell and will make your surgery more difficult. So I'm always telling the patient, I'll give you a little bit. If you start feeling something, I will give you more. And all these patients in topical, we have clearly an anesthetist present in the operating theater, and he's giving some propofol, but only little amount, so the patient is awake. I can talk to him.
Okay,
Emilio,
maybe
Emilio, do you use topical?
I use topical only for one muscle surgeries. And I do it with the presence of an anesthetist. And what I do is I put some drops of carbocaine, and the moment in which I pull the muscle, I ask the anesthetist to inject a little bit of propofol.
Okay. At what age do you start using topical anesthesia?
I live in Italy, and in Italy, children, you could never keep them calm for this type of thing. So that I would say the minimal age is 18, 20 years, and women are better than males. Males are more emotional.
Yeah.
I have a feeling that's true all around the whole world.
Yeah, same in Switzerland. Males starting age 90 and females starting age 18.
Can I just address one other thing just quickly? Maybe we can all agree on this because we all have differing opinions. What about a lost muscle? What incision do you use for finding a lost muscle?
Fornix.
I start with MIS, but sometimes clearly I have really to convert to open surgery. That's clear.
Okay.
What about you, Emilio?
Well, the possibility of converting to regular surgery has been very seldom. The problem is the selection of patients before.
All right, so we are just about up against the time of 90 minutes that we promised everybody. Are there any comments or last-minute wrap-ups that our panel would like to add that they wanted to make sure was clear?
Maybe one thing I would add is now traveling is not possible, but I have, when traveling will be again possible, I welcome always from all around the world people. Please contact me. I will be pleased to have you in Switzerland to watch. I will give you some tips. I'm sure Ramesh is offering the same. So I think it's good to be able to travel somewhere where a technique is done. Emilio, I'm sure, is also happy to see people. I think this is important to see the people doing the surgery and not looking only at the video or reading papers.
Thank you for your kind offer.
Craig, I'm sorry.
Thank you so much for inviting me on the panel. This has been fabulous, getting ideas from all over the world when we're all locked down and tucked away in our houses. So congratulations, and thank you again very much.
Craig, it's Sunday now for you, isn't it?
Yeah,
it is. It's Sunday. It's still May, but it's Sunday. Yeah.
Thank you, everyone.
Angela, did you want to say a few words as we close?
Yes, I would like to thank the World Society for this event and for include all the countries and to allow people to discuss and to ask questions, you know, and to share knowledge. And I have to point something out, David, and in my interest, that the CLADE webinar is going to be in May 4th. And it's just going to the CLADE web site, you know. So that's what's important for us to clarify. But thank you, everybody, for all these great discussions. And I have to talk to Ramesh about that 50-year mention, you know, of the Asia.
Yes.
We have to have a
I think
discussion later on.
I think all of us except Ning have to talk to Ramesh about that conversation.
Seriously.
So,
I would like to congratulate David, because I think that he has really changed in an incredible way the approach of teaching strabismus all over the world, and I think we all owe him a lot.
Well, you're very kind. You're all very kind. Thank you so much. And to all of you for giving your time today so freely. At the World Congress meeting scheduled in about 5 months, we plan to have a workshop like we've had before, where many of the teachers you see here have given of their time and sat around the table with models and taught practice surgery right there in front of you at the meeting to learn the techniques. I've been so impressed with how giving the world of strabismus and our whole field is in sharing knowledge and information. It's really a kind of an amazing and very wonderful thing to be a part of. For those of you who are online listening, and we apparently have had some 2,000 people again listening to us worldwide, thank you so much for joining us. There is an international listserv. To get on it, you have to email me, and my email is D, like my first name, David, D Granet, Granet, at my university, which is at ucsd.edu. So that's dgranet at ucsd.edu if you'd like to join the international listserv. We look forward to seeing everybody next week for our next seminar. It's planned to be for Brown syndrome, and look for our announcements for that. I think, Ramesh, you wanted to say a word before we finish?
Yeah. Thanks, David. It's just that I have to tell a few things before we close up. Number one is we have compiled more than 100 questions today. The panelists as well as the speakers are going to answer each of this and send it as a PDF file to all of you. Please make sure that you have the correct email there. That's number one. And all of us, there is one more survey we have just done. Unfortunately, because of the technical reasons, we are going to share that as well, along with the questions and answers with the feedback. And all of you feel free to write to us. How can we improve this? Additionally, the last thing, you all are free to join our WSPOS membership, which is free to everybody. You can watch interesting educational videos and some of the lectures, and we will have access to all the answers. We are totally conducting 10 webinars from the last week. So all the speakers are going to give their answers in a PDF file. So looking forward to having you, all of you. And I would like to thank entire team for putting this up and hosting this. They have done a fantastic job. It's not easy to coordinate with so many things, because with the 10 or 12 countries we need to manage in terms of speakers, as well as we are in different time zones. I really would like to thank the admins of WSPOS and all the Scientific Bureau and Executive Bureau. And most importantly, all the delegates that make our webinars very special. I think keep watching and keep giving feedback to all of us. Thank you very much.
Yes, and I'll close here by thanking Emilio, Ramesh, and Daniel for being willing to show their videos and take the questions from incredible surgeons like Craig and Ning, who have shared their viewpoints. And I must thank Angelita, my friend Angela Fernandez, for coming and joining us as well. The World Society is an open and inclusive place globally. We have 30 or 40 plus videos for you to watch, 18 cases with discussions. It's free to join. Please join this movement. Join the world of your colleagues. We look forward to seeing you all next time here in the webinar, here in cyberspace. Stay safe, stay healthy, and be well, all my friends. Thank you again.
Thank you. Thank you.
Thank you.